Hi friends, pathology of diabetes mellitus is going to be the topic we'll be discussing today. As we know, the pancreas mainly consists of both exocrine and endocrine portions, and the endocrine portion consists mainly of something called as islets of Langerhans, which has four major cell types called as beta, alpha, delta and PP cells, which produce beta cells will be producing insulin, alpha cells produce glucagon, delta cells produce somatostatin, which have in fact a negative effect on both insulin as well as on glucagon. PP cells produce something called as a VIP or vasoactive intestinal polypeptide, whose main function is to reduce the gastric motility and so on. This is how the pancreas looks. This is the normal histology, a beautiful histology of pancreas, and you can see here this portion is the exocrine portion, and you can see these lobules are separated by this connective tissue in between, and within this exocrine portion you can see a small island which is called as an islet of Langerhans. So this is the exocrine portion, whereas this is the endocrine portion of the pancreas. Now this endocrine portion of the pancreas will have all the four types of cells which we have mentioned earlier. They're called as alpha, beta, delta and pancreatic polypeptide cells. Also some say that they have epsilon cells which produce ghrelin, which causes hunger. So can we actually differentiate between these cells? Yes, we can. We can differentiate between alpha, beta, delta and pancreatic polypeptide cells based on their staining characteristic, based on some special stains which we can use, or the hormonal content they have. And surrounding this area you can see all these are acini which containing zymogen granules which have the function at the time of digestion. Now, definition and diagnosis of diabetes is basically it's a group of metabolic disorders which share the common underlying feature of hyperglycemia. This is one of the most important feature which will be seen, as we all know, in patients suffering from hyperglycemia. There will be defects in insulin secretion, action, or both, and we will be seeing how it will be having defects in secretion as well as in action. They are going to cause damage in multiple organ systems and will lead to end-stage renal disease. Most of the patients who are going for dialysis may be diabetes mellitus. Most of the patients who have adult onset blindness are again diabetic patients. Most of the patients who are having non-traumatic lower extremity amputations are going to be diabetics. Same is the case with coronary artery disease and patients suffering from cerebrovascular accident. It is so closely associated with obesity that we have this term called as diabetes plus obesity called as diabesity. If we have to do the blood glucose levels, we have different methods. One is called as a random blood glucose RBG, a fasting plasma glucose or FPG, and an oral glucose tolerance test. If RBG levels or random blood glucose levels are more than 200 mg per deciliter, the fasting blood glucose levels more than 126 mg per deciliter, and oral glucose tolerance test levels more than 200 gram per deciliter or higher, which is 2 hours after a 75 gram of glucose which is mixed in around 200 ml of water, we call it diabetes. Plus you have these three important features: polyuria, polydipsia and unexplained weight loss despite polyphagia. So these three important features, polyuria, polydipsia and polyphagia, you have to remember, are the very important clinical features of diabetes mellitus, along with the blood glucose levels which may fall under this range. There is a term called as pre-diabetes if the fasting plasma glucose levels are more than 110 but they are less than 126, and OGTT levels, oral glucose tolerance test levels, are more than 140 but less than 200 mg per DL, we call it pre-diabetes. Now, as far as function of insulin is concerned, it is a highly anabolic hormone. Now, it has various functions. Overall, we can say that its function is to increase the levels of glycogen by reducing the level of glucose. Its function is to increase the level of lipids, increase levels of fat, and increase the amount of proteins in the body. right? So it has anabolic function. Apart from that, it also has some functions on the DNA which we call as mitogenic functions. It will help in growth, it will help in DNA proliferation, it will help in differentiation of cells. So these are the major functions of insulin. Now we can see it causes increased glucose uptake, it causes increased lipogenesis and decreased lipolysis within the adipocyte. Within the striated muscles, including the myocardial cells, it will cause increased glucose uptake, increased glycogen synthesis, and increased protein synthesis. So they have increased protein synthesis, they have increased fat synthesis, and they have increased glycogen synthesis. And at the same time, they will reduce lipolysis, they are going to reduce gluconeogenesis, and they are going to have all these anabolic functions. There is something called as a glycated hemoglobin, which is actually one of the complications of diabetes, but we have used it as an important tool to measure the control of diabetes over a long period, and we shall come back to it a little later. But so far we'll just let you know that it is also called as glycosylated glycohemoglobin, hemoglobin A1C, hemoglobin A1, which is used to monitor the glycemic control of persons already diagnosed with diabetes mellitus. And now it has been included as one of the diagnostic criteria, in which if it's less than 5.7, it's considered as normal. 5.7% to 6.4% is considered as pre-diabetic, and 6.5% and higher is considered as diabetes. Now coming to classification of diabetes mellitus, it is being classified into various types according to American Diabetes Association's paper which was published in around 2008. There are around 10 types of diabetes, but the most important type of diabetes are type 1 and type 2 diabetes, and among these also majority of the patients which you will be treating later on will be type 2 diabetes. Now what happens in type 1 and type 2 diabetes mellitus? Okay, and it was formerly called as insulin dependent diabetes mellitus or juvenile diabetes, and it was formerly called as non-insulin dependent diabetes mellitus, but these terms are no longer used because we know that in this case you have some deficiency of insulin. In this case you don't have deficiency of insulin as such, but you still may need some insulin. So this term non-insulin dependent diabetes mellitus is no longer used. So around 10% of the cases fall under this category of type 1 diabetes mellitus. Now what happens in cases of type 1 diabetes mellitus? There is an attack on the islets of Langerhans, there is an attack on the beta cells by your own immune cells. It can be in the form of antigens which are affecting, which are causing damage to the islet cells, which are causing damage to the beta cells present inside the islet of Langerhans, or it could be because of the T cells which have lost the self-tolerance and they are going to attack your own cells, and they will lead to a pancreatic beta cell destruction. So this is because of an autoimmune cause. Type 2 diabetes mellitus, which is one of the commonest type, which is commonly seen in people of around 40 years, 50 years of age group. What happens in this? There is a combination of peripheral resistance to insulin. That means the cells are not able to uptake the glucose. The insulin's function is to help the cells uptake the insulin, but when there is something wrong with the cell's receptor, the insulin is not able to help the cells uptake the glucose. So the glucose will stay in your bloodstream and will lead to hypoglycemia. Now initially when there is a resistance, your pancreatic beta cells will try to produce more insulin and may produce a euglycemic, a normoglycemic state. But over a period of time, it is not able to compensate anymore. So there is an inadequate compensatory response of insulin secretion by the pancreatic beta cells. So in this case, we don't have a real insulin deficiency. We have a relative insulin deficiency. That means we need more insulin. right? We need more insulin in this case. The beta cells are perfectly fine. They are able to produce insulin, but over a period of time, they stop producing insulin. So we do need insulin in this case. So we have something called as a relative insulin deficiency, which is as compared to, in contrast to type 1 diabetes, in which we have absolute deficiency of insulin. So the absolute deficiency comes here and relative deficiency comes over here. There are some other types, like we have something called as MODY, which is maturity onset diabetes of young. Gestational diabetes, you have some diabetes which are because of endocrinopathies, like you have Cushing disease, you have acromegaly. It may be because of some problem with the exocrine pancreas, some kind of pancreatic inflammations, pancreatic neoplasm, pancreatic injuries. It could be because of certain infections like Coxsackie viruses, like rubella virus, like mumps virus, and so on. So there are different types of diabetes which can be seen, but type 1 and type 2 are the most common type. Now, discussing in detail about the pathogenesis of type 1 diabetes mellitus, we know that it is autoimmune in nature. There is destruction of the islets by the T cells, which will lead to reduction in the beta cell mass. There is a genetic susceptibility. Environmental influences are there. It develops in childhood, manifests at puberty, and is progressive with age. And because we have absolute insulin deficiency in this case, there is an absolute insulin deficiency, so we do need insulin supplementation in these individuals. And these people have something called as diabetic ketoacidosis, which is because of, now you don't have enough glucose, so the fat will be burnt, the fat will be oxidized and will produce ketone bodies, and these ketone bodies will cause acidosis, so it's called as diabetic ketoacidosis, and the patients may die because of diabetic coma. If you do not treat it, it will be fatal in patients of type 1 diabetes mellitus. In type 2 diabetes mellitus, there is decreased ability of the peripheral tissue to respond to insulin, so there is insulin resistance, number 1. Plus, there is also beta cell dysfunction that is manifested as inadequate insulin secretion in the phase of insulin resistance and hyperglycemia. Now, what happens is, initially you have insulin resistance, there will be a compensatory beta cell hyperplasia. The patients will be normoglycemic. There will still be impaired glucose tolerance. The beta cells will fail and will cause IGT, or impaired glucose tolerance. The beta cells will fail, will continue to fail, and will lead to overt diabetes. So what happens is, you have a beta cell failure. There is no damage to beta cell as such, but there is a failure of beta cells to produce enough insulin, so that there is enough insulin which can take care of the high glucose levels. So these patients have a relative insulin deficiency, as in contrast to patients suffering from type 1 diabetes mellitus, who have absolute insulin deficiency. Now, this is pancreas. We have seen this is exocrine portion, this is the endocrine portion, this is how it looks normally. Now, look here carefully, you can see a lot of inflammatory cells. All these are T cells which are causing a lot of problem, a lot of destruction of the islets of Langerhans in pancreas. Now, what would you think? Is it a type 1 or a type 2? Yes, this is going to be a type 1 diabetes mellitus, because you have, this is type 1 diabetes mellitus, because there is autoimmune destruction of the islets of the pancreas. This is going to be, in this case, you see there is no inflammation, but you see there is more of hyalinization, more of sclerosis, all this pinkish material which has been deposited, and there is lack of enough number of beta cells. So this could be because of amyloid deposition as well, which could be a part of diabetes mellitus, or which could be a part of amyloidosis as such. So in this you can see a lot of amyloid deposition, hyaline sclerosis of the beta cells of the islets of the pancreas. So there is no inflammation going on. So this could be in patients suffering from type 2 diabetes mellitus. Now, coming to the complications, they are of 3 important types. One is the microvascular disease, which are going to affect the kidneys, retina, and the nerves, and of course the immune-related problems, which may lead to infections like tuberculosis, pneumonia, pyelonephritis, candida, etc. in these patients. Now, why do these people have these complications? The first, it is mainly a kind of a biochemical process which is going on. So increased glucose, as we've seen earlier, there is going to be hyperglycemia, whether it's type 1, it's type 2, or any type of diabetes. The end result is hyperglycemia, and that hyperglycemia is not going to keep quiet. It is going to cause certain effects in your body, and those effects are going to cause some kind of biochemical problems inside your body in the form of advanced glycation. Now, if you have increased glucose, it is going to glycate everything. It is going to glycate collagen, it is going to glycate laminin, it is going to glycate polypeptides, it is going to glycate the basement membrane, it is even going to glycate the hemoglobin, the RBCs. And as we have seen earlier, HB1C or HbA1c, which is also called as glycosylated hemoglobin, we have discussed about that. So this glycosylated hemoglobin is actually a complication of hyperglycemia, but we have used it as one of the important tool to diagnose diabetes mellitus. Now, what happens when it actually glycates hemoglobin, which are present inside the RBCs, and we know the lifetime of the RBC is around 120 days. So we get hemoglobins which are glycosylated for 120 days. So we can actually monitor the glycemic control over a longer period of time. It is also going to activate protein kinase C with the help of glucokinase and stuff, and is going to activate VEGF, endothelin 1. It is going to produce increased amount of extracellular matrix. It will cause decreased fibrinolysis, will lead to inflammation, will lead to production of cytokines. All these things are going to cause a lot of damage inside the blood vessels. Plus, it is also cause intracellular increased amount of glucose. Now, you may think that, hey, insulin is supposed to help uptake of glucose inside the cell, and in diabetes there is reduced insulin. Then how come you have more amount of glucose inside the cells? Now, why it happens is because of increased amount of glucose outside the cell. So if you have a cell over here and you have a glucose which is present everywhere around the cell, this is going to diffuse inside the cell. So there will be increased amount of glucose inside the cell over a period of time. So this intracellular increased glucose is going to cause a lot of problems inside the cells and will not let any more. And this is going to activate the polyol pathways and will increase the levels of sorbitol and fructose inside the cells and will cause various complications, for example cataract in diabetic patients. So you have non-enzymatic glycosylation, that means you have advanced products of glycosylations, also called as AGEs. They are going to cause atherosclerosis and glomerulopathy. Now, why atherosclerosis? It is one of the macrovascular disease, right? So this atherosclerosis, now you may say that atherosclerosis is because of all that plaque which has been formed inside the arteries. It is because of smooth muscle proliferation. It is because of intimal degeneration, calcification. But hey, this is the same thing which is going to happen in patients suffering from diabetes mellitus. In diabetes mellitus also, you have increased glycosylation, and this is going to cause a similar effect which actually happens in atherosclerosis. So you really cannot differentiate the atherosclerosis because of actual atherosclerosis or atherosclerosis because of diabetes mellitus. Because anyways, you will have intimal proliferation, you have smooth muscle proliferation, you have activation of the macrophages, you have damage to the intima, you have smooth muscle proliferation, you have regeneration, you have inflammation. The same things which are going on in atherosclerosis will be seen here as well. Activation of protein kinase C, as we have discussed, is going to cause neovascularization by production of all the growth factors, VEGF, endothelin and all. They are going to cause neovascularization, which will also be seen in cases of diabetic retinopathy. Intracellular hyperglycemia with disturbance in polyol pathways are going to accumulate sorbitol and fructose and may lead to diabetic neuropathy and cataract. So all these complications of diabetes are basically having some kind of a biochemical process going on behind them. So we have to understand that why there is atherosclerosis. It is because of AGEs. Why there is diabetic retinopathy, neovascularization in diabetic retinopathy, which is because of activation of protein kinase C. Why there is cataract in patients suffering from diabetes, because of intracellular hyperglycemia, which is going to activate the polyol pathways and will cause production of sorbitol and fructose inside the cells. Now coming to the morphology, pancreas as such will not be of much of diagnostics importance, because you don't do a pancreatic biopsy in a patient suffering from diabetes, right? So pancreas are not going to be really useful, but we shall be having a look how pancreas may look like in type 1 and type 2 diabetes mellitus. Arteries, they may be a macrovascular disease, basement membrane of the small vessels will have a microangiopathic disease. Kidneys will lead to diabetic nephropathy. In case of retina, there will be retinopathy. In nerves, there will be neuropathy, which will be seen in both type 1 and type 2 diabetes mellitus, and we shall have a look at all of these one by one. Now what happens to pancreas? It is inconstant and has no diagnostic value. More important, more obvious features with type 1 diabetes mellitus, in which you will see that there is something called as insulitis. You may also call it eyelitis, because there is inflammation of the eyelids. So there is leukocytic, mainly T cell infiltration of the eyelids, and which leads to insulitis. In cases of type 2 diabetes mellitus, you mainly have hyaline degeneration. You may have amyloid deposition in the long-standing type 2 diabetes mellitus, and if you do a light microscopy, the amyloid will appear pink, and if you do polarizing microscopy, it is going to appear apple green. It is called as apple green birefringence. In diabetic macrovascular disease, it is going to cause atherosclerosis, which is going to affect the aorta, large and medium-sized arteries. It is going to affect the coronary arteries and will lead to myocardial infarction. It will cause atherosclerosis of the vessels of the lower extremities and may lead to gangrene of those vessels. In the kidneys, it may lead to hyaline arteriolosclerosis. So this is what atherosclerosis may look like. Diabetic microangiopathy, which is one of the most consistent morphological feature of diabetes, and there is diffuse thickening of the basement membrane. We know because of protein kinase C, there is activation of a pathway which is going to produce a lot of growth factors like VEGF, endothelin, and it is going to cause diffuse thickening of the basement membrane. Capillaries of the skin, muscles, retina, renal glomeruli, renal medulla may be affected. The basal lamina is thickened. There is concentric layers of hyaline material which is composed mainly of type 4 collagen. Now the basal lamina is thickened, the vessels are thicker, but still they are more leaky to the plasma proteins and mainly causes nephropathy, retinopathy and neuropathy. Now, what happens in nephropathy? It has glomerular lesions. It means the glomeruli will be affected. There will be renal vascular lesions in the form of arteriolosclerosis and pyelonephritis because of infections and immune related problems of the kidneys. So these glomerular lesions are in the form of diffuse mesangial sclerosis. That means there is diffuse sclerosis of the mesangium and nodular glomerulosclerosis, also called as KW lesions, which are very specific for diabetes mellitus, called as nodular glomerulosclerosis. So because of continuous ischemia, and why ischemia? Because of narrowing of the lumen of the blood vessels. Why narrowing of the lumen of the blood vessels? Because of arteriolosclerosis, atherosclerosis. So there will be a narrowing of the lumen which will lead to ischemia. There will be scarring of the kidneys, and you have a finely granular cortical surface, and if you try to remove the capsule from the kidney, which is very easy to remove, and if it is having all this scarring over it, it is very difficult to strip that capsule off the cortical surfaces of the kidney. This is how it looks like. You can see this is all nodular glomerulosclerosis. This is the finely granular cortical surface, and you can see that there is a lot of ischemia. Because of a lot of ischemia, there's a lot of scarring on the surface of the kidneys, which is quite a characteristic of diabetes mellitus. And you can also see a cyst over here, which is an incidental finding. Maybe just without any problem, this patient is having this cyst as well. Renal vascular lesions in the form of arteriolosclerosis will cause renal atherosclerosis and arteriolosclerosis. There will be pyelonephritis because of acute and chronic inflammation of the kidneys. Interstitial tissue and tubules will be affected and may lead to necrotizing papillitis. Ocular complications are in the form of retinopathy, cataract formation, and glaucoma. It is a non-proliferative retinopathy and a proliferative retinopathy. What happens, this is how retina normally looks like. This is the optic disc, this is the fundoscopic image, and here you can see a lot of blood vessels which are seen over here. You can see a few hemorrhages which are here. You can see these cotton wool exudates. So you have these important features which will be seen in these individuals in the form of these these are cotton wool exudates. You have these hemorrhages, or you may have some thickening of the blood vessels in the form of micro aneurysms. Right, so you have hemorrhages, you have cotton wool exudates, and you have these microaneurysms. You can see here there is retinal detachment. You can see a lot of hemorrhages over here. So all these are the features which are seen in patients suffering from diabetes mellitus. Along with that, the patient may have cataract or glaucoma. Now these features, these complications of the eye are because of a different metabolic pathway or different complications, different biochemical pathway. Diabetic neuropathy, which is peripheral symmetric neuropathy of the lower extremities that affects both motor and sensory, but sensory is a little more than the motor. Bowel and bladder functions are also affected. It may cause diabetic mononeuropathy and may lead to foot drop, wrist drop, or even cranial nerve palsies. So these are different complications. They can be microangiopathic cerebrovascular infarcts and hemorrhages because of atherosclerosis. Patient may suffer from hypertension because of the same reason. Atherosclerosis of large aorta, of the large arteries. There may be nephrosclerosis. There can be glomerulosclerosis, arteriolosclerosis, pyelonephritis. There can be islet cell loss of type 1, and in cases of type 2, there will be deposition of amyloid, myocardial infarction because of atherosclerosis. They may be having retinopathy, cataracts, and glaucoma in the eye. They may lead to peripheral vascular disease in the form of gangrene and infections. They may have peripheral neuropathy. They may have autonomic neuropathy. So all these are the complications of diabetes. And here, how we differentiate between type 1 and type 2 diabetes mellitus. The onset is less than 20 years. It is after 30 years. Normal weight. These people are generally obese. There is a markedly decreased blood insulin level. So there is an absolute insulin deficiency. In this case, there is an increased blood insulin earlier, but after that there will be decreased insulin towards the end. There will be antibodies to the islet cells in this case, and there will be no antibodies to islet cells in this case. Ketoacidosis is common. In this case, there is something called as non-ketotic hyperosmolar coma, which will be seen, but ketoacidosis is rare in these individuals because there is no absolute deficiency of insulin in these individuals. Genetics play a role in both of them, but it is more commonly affecting the type 2 diabetes mellitus. They have MHC class 2 HLA genes linkage. In this, there is no HLA linkage. It is mainly because of autoimmune destruction of the beta cells of islets of Langerhans by T cells and those antibodies. So there is an absolute insulin deficiency. In this case, there is an insulin resistance, plus there is a beta cell dysfunction. The islet cells, there will be insulitis, there will be atrophy, fibrosis, and beta cell depletion, whereas in this case there will be no insulitis, there will be focal atrophy and amyloid deposition, and there will be a mild beta cell depletion. So that's with that we end with diabetes mellitus. Thank you so much for your time.